You are listening to the Blood Bank Guy Essentials Podcast, episode 019.
Hello, everyone, and welcome to Blood Bank Guy Essentials number 019. I'm your co-host, Heidi Shafi, and with me today in the hot seat is Dr. Joe Chaffin. So, Joe, how does it feel like to be the one in the hot seat?
Well, I'm not sure. I haven't decided yet because I can't tell how mean you're going to be to me today, Heidi. So we'll check at the end, I think.
Exactly. You'll just have to wait and see. So, Joe, before we get into today's topic, I was going to ask you a couple of questions that you ask all of your guests.
Oh, boy.
And one of them is, how did you get into pathology and in particular blood banking?
Well, for me, Heidi, that started back in medical school. When I went to medical school, I told my family that the one thing I would never be is a pathologist, and there's a really simple reason for that. My brother is a pathologist. My older brother is a pathologist, and he's a brilliant guy. Practices up in Boise. He's my hero, always has been. But honestly, the last thing I wanted to do was follow in my older brother's footsteps. I told my family, literally, I will never be one of those nerdy pathologists. But as I got into my third year of medical school and started doing the clinical work, I really started noticing that I really was bad with the scenario when bad stuff happened to my patients. It was really, really hard for me emotionally, and I didn't really know how to deal with it. And quite honestly, I didn't get a lot of guidance at the time on how to deal with it. So I started thinking about, well, maybe for me, I'm not speaking for anyone else and not criticizing anyone that does patient care, but maybe for me, it's just not the right choice. Right. So I started investigating some other things that were, things like pathology and radiology, and where you weren't necessarily day-to-day involved in patient care. And I really, really liked pathology, much to my chagrin at the time, and just decided to do that. Now, for blood banking, that came, it was kind of a culmination of many things. During my internship, before I actually became a pathology resident, I did some pathology rotations there as well. And it started to dawn on me that some of the people that did anatomic path were a little less involved in human interactions than maybe I would have liked. One vivid memory is of seeing one of my anatomic pathology staff this is when I was an intern, actually talking to a clinician through a door. He wouldn't open his door to talk to the doctor. It kind of frightened me. And
wait, you would stand on like the other side of the door?
Yeah. It was hilarious. It's an incredibly vivid memory. And I'm certainly not painting anatomic pathologists with that kind of a brush. Don't take me wrong. Don't send me emails, anatomic pathologists. I love you guys. I did that for years too. But I realized that for me, the clinical pathology side was probably a little bit more interesting. And then when I got to my internship, my second rotation was in blood banking, and I fell in love. I knew right away that was really what I enjoyed. That human interaction combined with the day-to-day investigation of problems and interaction with clinicians, and in some cases taking care of patients. It was really for me a perfect blend that got both all aspects of my personality. So that's how I did it.
Got it. So my second question, now that I know how you got into blood banking, is how did you get into teaching blood banking?
That didn't really totally materialize until my first week as a staff member in pathology. I was really, really fortunate. I did my residency at Walter Reed Army Medical Center in Washington, D.C., and was just incredibly blessed to move directly from one day being a senior resident, and the next day being the medical director of the Walter Reed Blood Bank. It was a pretty amazing thing. It's kind of typical for the Army. You get put into things that you're probably not quite ready for, but the responsibility is yours, so go for it.
Right.
And I'd always enjoyed teaching. I did tutoring when I was in college and really enjoyed that aspect of it, but didn't really realize during my pathology residency how much I liked it until the first day, the first week as a pathology staff member and in charge of teaching these young residents at Walter Reed Army Medical Center who I'd been colleagues with the day before, literally. Suddenly I had to be the one that was teaching them blood banking, and it was for me, it was instantaneous and almost magical just how much I loved it and how quickly I took to it, and how much I realized right away I love doing this, and I've never really looked back. It was something I really think that when you are doing something that is right and that is right, right away, and that's exactly what it was for me. I knew that I loved teaching pathology residents and other students of blood banking as well.
And through your BB Guy site, you've reached many, many more, I think, students than you would have just, teaching at a program. So
I've been fortunate with that.
You're doing, and we really appreciate it. So, Joe, since we do have an interesting topic to talk about, I am going to start, if that's okay with you.
Bring it on.
Okay, so everyone, today is an Ask the BB Guy session. So this is when these topics are driven from questions that you sent, Joe, on the site. And today's topic is cryoprecipitate. And one of the questions that we did receive was from John K. in Detroit. And he asked, Dr. Chaffin, I don't understand cryoprecipitate. It's such a weird product. It looks like a miniature FFP, but people don't use it like FFP. It seems like many doctors don't understand how to use it either. I had a doc order a single unit to make some sort of glue, but we don't have single units anymore. Another surgeon was upset that cryo was not part of our trauma pack. I'm just confused. Can you help me understand? So with that, Joe, can you tell us a little bit about cryo?
I can. I love this question. Well, first, shout out to John K. in Detroit, my hometown. Detroit, woo! Okay. Forgive me, everyone. That's anyway. What John said in his email is really, it's not only not surprising, it's fairly typical. I would really say that out of all the main blood products that we talk about, your red cells, your plasma in its many forms, but fresh frozen plasma, typically your platelets, cryo, of those four main blood products is really by far for me the most misunderstood. In fact, we used to say a long time ago, back when I was a resident, that a cry for cryo was a cry for help, basically, because it's uncommon. At least in those days, it was uncommonly used. It's being used a whole lot more recently in certain situations and in certain countries, and we'll talk about that. But despite the fact that cryo has been around for a while, there's still a lot of misunderstanding surrounding cryo. There are definitely, as we'll talk about, decreasing numbers of indications for cryo as different other products have become available that do some of the things that we used to have cryo to do. But in the countries where cryo is still used, the United States being one of them, we actually are seeing a little bit of an increase in use. And there's, again, some reasons behind that. But I wanted to make sure that we covered this topic just because, as I said, certainly among clinicians, but also among clinical staff and pathology residents, I think there is a significant amount of misunderstanding around cryo. So I thought this would be a great topic for an Ask the Blood Bank Guy session. And as we do these, I'm trying to focus these things into what I call the essentials. So I'd like to cover 5 essentials about cryoprecipitate today.
Perfect. So can you let us know, in your opinion, what are the 5 essentials that we should know about?
Yeah, you bet. I'd be happy to. So the 5 things that I want to cover today, the 5 essentials are: number 1, how it's made; number 2, what's in it, what's in cryoprecipitate; number 3, how we prepare it for transfusion; number 4, how it's used, and we'll spend most of the time on how it's used; and then finally, what's the future for cryoprecipitate.
Okay, so let's start with the number 1 essential. How is cryoprecipitate made?
Well, I'm kind of a history nerd, and I love reading about history. And I came across a really cool story. Dr. Paul Schmidt was writing about this in an AABB book from 2011 called Blood Component Preparation. It's actually in the first chapter, just an introduction to the different blood products. And he tells a story that I love, and I'm just gonna paraphrase it. But basically, over 50 years ago, in the early 1960s. The hematologists that were treating patients with hemophilia A were trying to come up with a way to treat them efficiently. And previously, I guess they had used just fresh frozen plasma, but they had become concerned that once the FFP was thawed, the factor VIII levels declined fairly rapidly. And so they wanted to have a better product to do that with. So I guess in the AABB standards from 1963, there was a mechanism proposed to give people kind of a different form of FFP. A form of FFP, I would call it slow thawed, basically. You thaw it really slowly, and as it gets to the point where it's not quite all the way thawed, there's still some ice crystals in it, then you transfuse it really fast, because that'll give them the best bang for their buck with the FFP. And it seemed like a cool idea because, again, the longer you wait, certainly we know that now, the longer you wait with factor VIII sitting in a bag of blood, of thawed plasma in particular, the more that factor VIII level does decline. But when they tried to transfuse that stuff, Heidi, that kind of barely thawed FFP, basically what they found was not only were there's ice crystals in it, but further, there was this gunk in it, this icky stuff that kind of slowed the flow of the plasma down. And as that stuff was flowing in, they realized later that they weren't getting the effect that they wanted from the factor VIII in that as well. Well, we kind of know the story now, but at that time, nobody really could figure it out except for Dr. Judith Poole and her team at Stanford. They actually thought about it, and they looked at the gunk that I mentioned, and they analyzed it, and they said, oh, wow, wait a minute, there's most of the factor VIII. So it was
like kind of like a serendipical, how do you say it?
Serendipitous, yes.
Yeah. Thank you, Joe. No, that's okay. Okay.
That's awesome. So yes, exactly right. It was totally serendipitous. It was just a kind of a happy accident. And she and her team at Stanford published the first real description of making cryoprecipitate by slow thawing FFP back in 1964.
So take us through it. How do we make it these days?
Nowadays, it starts with fresh frozen plasma. So I'm going to talk a little bit about. I'm going to talk mostly about how we do this in the United States. I know from looking at the downloads that people outside of the United States also listen to this podcast. I'm totally aware of that. So I'll be mostly focused on how we do it in the U.S. because there are some slight differences, but I'll try and point out where things are different outside of the U.S. as well. But in the United States, we are required to start with not just fresh frozen plasma, but whole blood derived fresh frozen plasma. And we don't want to take a whole lot of time to go into this, but certainly in the United States and in most countries, you can make FFP from either a whole blood process where you collect whole blood and then spin it down, separate it, and separate out the plasma, put it in the freezer within 8 hours generally, or by making that product from an apheresis collection where plasma comes off the machine and you put it in the freezer generally within 6 hours. Anyway, but the bottom line is that in the United States, you have to make cryo from a unit of whole blood derived FFP. That's not true everywhere. Apheresis can be used in other countries, but in the US, whole blood derived. Now, normally when we take that FFP, we put it in the freezer, I should say, as I mentioned, within 8 hours. We store it at less than or equal to minus 18 degrees Celsius. That's a really important number for those of you studying for exams to remember. So FFP up to 1 year, minus 18 degrees Celsius. That number, again, is somewhat different elsewhere, minus 25 in most other countries, but minus 18 in the US. And we keep it for that time frame. We can thaw it and transfuse it up to that 1 year. And when we thaw it in a nice, warm, happy water bath. And it's near body temperature, 30 to 37 degrees Celsius. And basically at that temperature, all the proteins just dissolve nicely into the fluid, and you have a nice fluid unit of fresh frozen plasma to transfuse. the other thing to remember is that once FFP is thawed, we actually normally would put it into the refrigerator at 1 to 6 degrees, where it's kept anywhere from 1 to 5 days. And again, that's topic for another day. There's some details to that you should be aware of, but we'll talk about that another time. So that's what we normally do with fresh frozen plasma. If you're going to make cryo, though, things are a little bit different. So I mentioned before, with FFP, we thaw that unit at 30 to 37 degrees, most commonly in a warm water bath. Instead of that, with cryo, you want to slow thaw it. And if you're going to slow thaw a unit that's used to being at minus 18 or below, you're not going to put it at body temperature. You're actually going to put it at a temperature roughly 1 to 6. In fact, not just roughly, definitely at 1 to 6 degrees Celsius. And again, most blood centers will do that in a refrigerator. Just put it in a refrigerator, because that's already the temperature that we store red blood cells and whole blood, at 1 to 6 degrees. They'll put them in a corner of the refrigerator, and it's not quite that uncomplicated, right? They don't just find some corner of the refrigerator and put the plasma in. They'll normally have different parts of the refrigerator, or for refrigerators that are defined as being used for that slow thawing of cryo. They'll put it there and they'll thaw it typically overnight. That's the most common way that it's done. And as the plasma thaws, it obviously is going to thaw very gradually. But as it thaws, just like we saw historically over 50 years ago, you're going to get to the point where it's just about thawed, there may be some ice crystals in it, and you can even let it thaw all the way to the point where it's where all the ice crystals are gone. But most people will get it when it's still a little bit slushy. Then they'll take it, and they'll put it into a refrigerated centrifuge and spin that sucker down. Because what we find when you slow thaw it that way, just like Dr. Poole found and the hematologist found and the blood bankers found over 50 years ago, is that some of the proteins are not soluble at that 1 to 6 degrees Celsius. In other words, they precipitate, they stay in solid form rather than dissolving into liquid form. So you put that slow thawed unit of FFP, generally a bunch of units at the same time, but you put that slow thawed unit into a refrigerated centrifuge, and you spin it pretty hard, about 5,000 times G, 5,000 times the force of gravity, for between 5 and 7 minutes. And what you end up with when you take it out of the centrifuge, and I'll have a picture of this on the show page of the website, because it's really cool when it's done well. You at the bottom of that bag, you have this really dense, kind of firm appearing. It's sometimes just a film on the edge of the bag, but sometimes it's pretty chunky actually, and you can feel it. That's this solid precipitate at the bottom of the bag, whereas everything on the top of the bag is just a liquid unit of plasma, or it would appear to be anyway. You turn that sucker around, hang the bag upside down, express off the plasma, and you're left with the dense precipitate. Now, normally we're not going to leave it that way, Heidi, and that would make sense. You want to transfuse that. So in the United States, we typically leave about 10 to 15 mils of that plasma in the bag and resuspend it. You kind of massage it basically, and you resuspend that precipitate into the solution, and then finally refreeze that product.
Okay. So then, how long is that product good for?
This is something that does confuse people sometimes. So it's important to recognize that cryo, once it's made, has a shelf life that actually is identical to the shelf life of the original FFP. In other words, what we say with cryo, it's stored in the United States exactly like we store FFP, minus 18 degrees Celsius or colder, for up to 1 year. But you don't get to reset the year. In other words, that 1 year starts from the date of collection, just like the storage for FFP does. You can make cryo from FFP really theoretically up to the day that the FFP expires. Nobody would do that because the cryo would then still expire the same day you make it. That wouldn't make sense to do. But say if you're 2-3 months down the line and you make cryo, again, cryo is going to expire at the normal expiration date of the FFP. In other words, 1 year from the date of collection.
Got it. And Joe, I know you mentioned that we do leave about 10 to 15 mLs of plasma still in the bag. So can you touch on the old terms, wet cryo versus dry cryo?
Oh yeah, sure. I love them.
And if those are still used?
Well, they're not really used all that much anymore, Heidi, to tell you the truth. But every now and then you'll get a request from someone saying, I'd like some wet cryo or some dry cryo. Normally it's done by clinicians who have been around for a while. It is defined, the technical manual defines wet cryo as cryo that has more than 15 mLs residual plasma per unit, whereas dry cryo is defined as less than 10 mLs per unit. Again, blood bankers don't usually use that terminology. And for us, since we're pooling for the most part now anyway, that's kind of generally irrelevant. But those are terms that occasionally you'll hear, and the tech manual mentions them, but I wanted to make sure that most people had heard of them.
Okay, so Joe, why don't we talk about actually pooling right now? Because,
Sure.
as John from Detroit mentioned, sometimes somebody will request a single unit of cryo because they want to make glue, but we don't really carry single units because we carry pool cryo. So how do we make pools of cryo?
Yeah, you bet. That's actually it's a really important point. For years, for decades, in fact, after Dr. Poole, ironically, described how we make cryo. Cryo was issued as 2 transfusion services from blood centers as individual single units. Generally speaking, before people would issue that product for transfusion, because it's such a tiny volume, giving individual bags just didn't make a whole lot of sense. So in other words, imagine if you're a nurse and you're getting ready to transfuse someone, and the typical quote unquote dose, historically anyway, of cryo was 10 bags. Okay, so we give you 10 bags that each contain about 15 cc's of plasma of cryoprecipitate. And so you're going to actually sit there and transfuse one bag, then transfuse another bag, and it would be really an inefficient use of a transfusionist's time. So transfusion services developed the idea to pool the product, and they would pool the product themselves in the transfusion service, typically sometimes under closed and sterile conditions, sometimes under open conditions, and we'll talk more about that later. But basically, getting the product into one bag. Well, what we realized for the blood center perspective, as time moved on, was that wouldn't this be easier on the transfusion services if we just did this up front? And so now most cryo, and it's not universal, but most cryo made from blood centers is actually pooled. So we talked about the fact that when we're making cryo, we express most of the plasma from the bag, leaving about 10 to 15 cc's, and that's an individual single unit of cryo. Well, most blood centers nowadays will take typically, most commonly, 5 of those bags, usually of the same ABO type, pool them all together into one bag, and then freeze basically a 5-unit pool of cryo. And it has the same expiration time, 1 year from the date of collection. And in fact, 1 year, if you use cryo products from different days of collection, basically the one that would expire the earliest would be the one that you give that 1 year expiration date to. But anyway, you're doing all this and pooling it. And as I said, 5 is the most common. I've seen pools up to 10, but most commonly they're 5, 6, 7, or 8. In fact, I would say most commonly either 5 or 8. For the most part. And anyway, so you take that product, you pool it into the one bag, you put it back in the freezer under the same conditions as you're storing FFP. There is one kicker to that. All that has to be done within 1 hour of the time that the product is separated. 1 hour from the time that you start the centrifugation, typically. So you got to move quickly if you're making cryo pools. But that all has to happen on a very rapid basis. Again, what that does is it just makes it easier on the transfusion services because they don't have to pool it, and it makes it easier on the transfusing staff because they don't have to transfuse individual single units, which they typically wouldn't want to do anyway. So Heidi, I just realized there is one more thing that I do want to mention before we moved on to essential number 2, and that's this. I talked before about when we make cryoprecipitate and we do that slow thaw and we spin down the product, and the liquid part is expressed off, and it kind of goes into the vapor, it would seem. But actually, it doesn't just go into the vapor. That product, the liquid part, after you thaw cryo and express off the liquid plasma, that actually has a name. It's called cryo-reduced plasma, or plasma, cryoprecipitate reduced, if you're looking for the true name. name. Some people call it cryosupernatant. And it's kind of a mystery product. It really doesn't get used all that often. The main indication for the use of CRP is thought to be in patients with thrombotic thrombocytopenic purpura as an exchange fluid. We're going to talk in just a minute about what's in cryo, but obviously cryo-reduced plasma would have less of the things that are in cryo, and that would kind of make sense. And the von Willebrand's factor in particular could play a role in making CRP useful in patients with TTP. Again, it's not used all that often, but I wanted to make sure to mention it.
So, essential number 2. Can you tell us what's in cryoprecipitate?
Well, I've danced around that a little bit,
Right.
but yes, I will happily tell you what's in cryoprecipitate. And really part of the answer, at least historically, you already know the answer historically because we know why it was made historically to give someone factor VIII. And in fact, if you look at the full name of cryoprecipitate, according to the regulations in the United States, cryo actually has a full name. It's not cryo, it's not cryoprecipitate even. It is actually cryoprecipitated antihemophilic factor. That's kind of a long name that most people would kind of go, huh? Just call it cryo. And we do, obviously. But the reality is that the antihemophilic factor part of the name refers to factor VIII. We discovered long ago, Dr. Poole outlined the fact that that precipitated part of the plasma when it was slow thawed is a very rich source of factor VIII. So factor VIII is the big thing that we find in cryoprecipitate, even though we don't necessarily use it for that anymore.
Okay, so what else?
Well, so that's the big one. In terms of how we use it nowadays, the big thing that's in there is fibrinogen. So there are 5 main components, and I want to make sure that if you're a student in particular, you know all 5 of these. Heidi has sat across the table with me as I'm talking with residents about this, and I will ask this over and over again because it really is important to remember. In part because remembering these will help you remember how cryoprecipitate is used. It just makes sense, right? So the 5 main components are factor VIII. You can call it factor VIII-C, that's fine, but factor VIII, fibrinogen, von Willebrand's factor that people tend to forget that from time to time, but von Willebrand factor is also a key component. Factor 13, the unlucky coag factor, as I tell people to try and remember it. And the one that everybody forgets that honestly it's probably okay if you forget is a weird substance called fibronectin that is also there. So let's do it again, okay? Factor VIII, fibrinogen, von Willebrand factor, factor 13, and fibronectin. Keep that firmly in your brain, everyone that's listening to this.
Joe, can you tell us about any regulations about the minimum requirements for the amount of those factors in cryo?
Yeah, again, this will vary a little bit from country to country. In the United States, we're actually lucky because we've only got a couple of things that have to be, in terms of quantity requirements in cryo. And those 2 things are, for factor VIII, there has to be at least 80 international units in every bag of cryo that we test. And for fibrinogen, there has to be at least 150 milligrams of fibrinogen in every bag that we test. And there really are no other requirements. So again, what that means in the United States is that there are no minimum requirements for von Willebrand factor, factor 13, or fibronectin. So 80 of factor VIII, 80 international units, 150 milligrams of fibrinogen, and that's in every bag that you test. Now, in other countries, as I mentioned, there are some differences in Europe and United Kingdom, and I believe in Australia as well. The numbers are slightly lower. Factor VII is 70 international units per bag. Fibrinogen is 140 milligrams per bag. Again, that's opposed to 80 and 150. And also in most of those countries, there's a von Willebrand factor requirement of 100 international units per bag that we don't have here in the United States. And just to be clear on that, the way that cryo is made nowadays, we're way beyond those minimum numbers. It's not even close. We get a whole lot more in the bag than 80 and 150 of factor VIII and fibrinogen respectively. So it's not even close.
Okay. And so aside from the fabulous 5 components that you mentioned in cryo, are there any other things in cryo?
That's a great question. this is one of the things that I think that sometimes we get a little bit of a false idea about cryo in our minds, because really, when you think about it, we talked at the beginning about how we make cryo, and we make cryo by precipitating out those five main things. But people forget about the last step. In the last step, you actually put in 10 to 15 mLs of plasma, and in other countries as much as 40 mLs of plasma. And it's just plasma, right? It's plasma that, okay, it has some of those hyper concentrated things of the five main factors that are in higher quantity, but everything else is not far from what's normally in plasma. So when you think about it, everything else is in cryo, at least a little bit. I mean, so you have all the plasma proteins in there. They're just in non-concentrated form. So that includes other coagulation factors. That includes ABO antibodies, though it's really a much smaller amount than you would see in a typical bag of plasma, a much smaller amount. In fact, for ABO antibodies, it's been reported that you've got in the range of, I don't know, like 1 to maybe 5% of the original amount of ABO antibodies. And that's just really, for me, it's just volume related. It's just a smaller volume of plasma that's in there, but it's still there. We can't ignore it. There are other things there are things that are normally in plasma that are going to be there. And the other thing that is interesting, actually, because I've seen reports that I didn't really understand historically about people making antiplatelet antibodies when it appeared that all they were exposed to was cryoprecipitate. A few reports like that, and we actually now have an answer for that. What we didn't know before and until fairly recently, I think. Again, I'm not certain about when this was discovered, but I became aware of it fairly recently. That the cryoprecipitation process actually concentrates platelet membrane microparticles, which are basically just little fragments of platelet membranes that carry all the platelet specific antigens on them, and even potentially HLA antigens on them. And there's a very large amount of those in cryoprecipitate. We're not really sure what they do. I mean, there's been some thought that those platelet microparticles might make cryo work better. In other words, it gives some platelet effect. That's not clear, and nobody's really figured that out. But they're definitely there, and they definitely are something that we should remember.
Wow, I had no idea about the platelet membrane microparticles.
Mm-hmm. Yeah, most people don't. I like I said, I really just became aware of it fairly recently.
Wow. Okay, so far we've learned a few things, but just to summarize, we know how cryo is made by slow thawing whole blood derived FFP, and we know that we can store it up to 1 year in minus 18 degrees or cooler. And we know what's in it. We know that we have 5 components, but the 2 that are particularly regulated is factor 8, which we need 80 international units of, and fibrinogen, which we need at least 150 milligrams. And then, as you mentioned, von Willebrand factor 13, and fibronectin, which I really don't know what it is, but it's in there. So let's move on to how do we prepare it once we need it for transfusion. So it's in the freezer and we get an order for cryo. What do we do?
Okay. Well, fortunately for us, that's actually pretty easy because it's really similar to what we do for FFP. We've talked about FFP earlier in the podcast, where we mentioned that when we're getting FFP ready for transfusion, normally we'll thaw it in that 30 to 37 degree, typically water bath. There's some alternatives to that, but most commonly a water bath. And making cryo starts out exactly the same way. We take it out of the freezer, we put it in that water bath, we thaw it near body temperature, and it happens really pretty quickly. If you're talking about a pool of cryo, which in most cases we are in the United States, those pools thaw in the range of 20 to 30 minutes or so, typically a little bit faster than FFP will thaw. Single units obviously are going to thaw a whole lot faster than that. But unlike FFP, and here's where the road diverges. And the way I always teach this is that we already know with cryo that the proteins that are hyperconcentrated in cryo don't like being at 1 to 6 degrees. They precipitate. They stay in solid form at 1 to 6 degrees. So that's how you can remember, if you're trying to remember, that cryo gets stored differently after thawing than FFP. With FFP or PF24, either way, you're going to take that product after it comes out of the water bath, and if it isn't transfused right away, it's going to go in the refrigerator at 1 to 6 degrees Celsius. Well, the proteins in cryo don't like that, so we're going to actually store it at room temperature, 20 to 24 degrees after thawing. And that's a really important thing to remember. Not 1 to 6 like FFP, but 20 to 24 after thawing. It also is very different how long you can keep cryo after you thaw it. Again, with FFP, with some variations, you can keep the FFP once it's thawed for at least 1 day, and with a little bit of manipulation up to 5 days, but you don't even get close to that amount of time with cryo. And that primarily is because of, in the old days when it was being used for factor VIII deficiency or hemophilia A, we already know that at room temperature, the amount of factor VIII is going to go down fairly rapidly in a bag of blood. So for that reason, we have a maximum shelf life of 6 hours after thawing that you can keep that unit of cryoprecipitate, a maximum of 6 hours.
Okay. So maximum of 6 hours if it's a single unit.
Right. If that's a great point, Heidi. If it's a single unit, it's 6 hours. And actually, if it's what I described earlier, where the product is pre-pooled under sterile conditions in a blood center before it's even frozen, a pre-pooled unit, a pool of typically 5 or 8, that will also have a 6-hour shelf life once you thaw it. But as I mentioned before, in the old days when we were doing single units and those single units were pooled in hospital transfusion services, in those cases, if it's pooled in an open system, you actually only get a 4-hour shelf life. That confuses the heck out of students. So let me just say that one more time. So we thaw a unit of cryo. Let's say it's a pool, pre-pooled. You get 6 hours to transfuse it. That's the most common scenario. However, if you're thawing a single unit and then pooling that with other units, and you're not using what we call a sterile docking device, in other words, it's an open system, then you only get a 4-hour shelf life. So in most cases, you don't have to worry about the 4 hours because most transfusion services don't pool cryo anymore. But if you should, you only get a 4-hour shelf life.
Got it. Do we have to worry about blood type? Does it have to be type specific when we transfuse it?
There are a little bit. Let me qualify that. In terms of full blood type, for RH, you don't have to worry about it. Just like with fresh frozen plasma, you don't have to worry about RH. Side note: the reason for that is primarily because there's essentially no red cells in there, and even if they are, they don't survive the freezing and thawing process. So there's really not anything in terms of Rh positive red cells to worry about immunizing an Rh negative person. But with ABO, you get some varying opinions. That, as I mentioned before, you get about 1 to 5% of the original ABO antibodies are present in a unit of cryoprecipitate. So they're there. There's no question that they are there. But realistically, small volumes like this typically don't cause patients problems. So in most cases, you really don't have to worry about it much. But I would tell you that most facilities will try to they'll really try to follow similar rules to FFP compatibility rules. In other words, you usually wouldn't give a unit of group A plasma to a group B person deliberately and on an ongoing basis, or give a unit of group O plasma or cryo to a group A recipient. You generally wouldn't do that. So even though with cryo, you could probably, and for smaller volumes, it probably wouldn't be any kind of an issue. Might give you a positive DAT, direct antiglobulin test. But generally speaking, you don't have to worry about it too much. To be honest, though, the way most people practice is they'll still follow the same rules, just in case you end up giving a whole bunch of that cryo product.
Okay, so let's move on to essential number 4. What should we use cryo? How do we use it?
Well, Again, this has changed as the years have gone by. Originally, we've beaten this to death. Everyone knows that it was historically used for factor VIII for hemophilia A patients, and unfortunately, this is one of the products that was really very heavily involved in transmitting HIV in the early '80s, late '70s, early '80s, before we realized what was going on. Generally speaking, we don't use it. In the United States, anyway, we don't use cryo for factor VIII anymore. So really, there are safer products, virus inactivated products, recombinant products of factor VIII concentrate that work great. So in the United States and most developed countries, we don't use cryo anymore. However, and for factor VIII replacement, I should say. However, I have to mention that I just tossed out on Twitter and Facebook a few days ago just some looking for ideas from people that follow me in one of those two places, and just asking, in your people that don't work in the United States, how is cryo used in your countries? And I got more than a few comments from people in other countries that say that while those factor VIII concentrates are available in their countries, still cryo gets used because it's less expensive. And I get that, but it's a little bit to a blood banker who knows the history of what happened in the '80s with HIV. That's a little scary. And like I said, in the United States, we would not do that now. But there are definitely some other places in the world where cryo is still used for hemophiliacs, and it's primarily a financial decision. I would say it's certainly a lot safer now. In fact, way safer now to do that than it used to be, because obviously our testing has improved dramatically. But I hate to say that it's not used for hemophilia A anymore, because it is in other places, just not in most developed countries.
Well, Joe, I have to interrupt you before you proceed with all the other uses. Is that, Twitter and Facebook are so yesterday. You need to get on with Instagram and Snapchat. I'm just saying.
Well,
but you can go on now.
You young one, whatever. Anyway, okay. So with that,
you're forgiven.
Okay, thank
Proceed.
you. Okay, so with that out of the way, the factor VIII. Let's go back and think about the main things that are in cryo. When we've already said it, we've got factor VIII, we've got fibrinogen. We've got von Willebrand factor, factor 13, and fibronectin. Okay, so the next on the list is fibrinogen, and that's really where we're going to spend virtually all our time in this section. Fibrinogen, the use of cryo to replace fibrinogen primarily for acquired hypofibrinogenemia. In other words, someone who didn't inherit a lack of fibrinogen, but they get it from something that's going on with them. That is the number one use of cryoprecipitate worldwide today. Now, I should tell you that, like other blood products, we really don't have a ton of great data for this. In other words, if you're looking for a whole bunch of evidence-based practice to say why we use cryo in these situations, you're just not going to find a whole lot about it. But that's really not just true for this product. It's true for virtually every blood product that we have, that there's not a huge pool of randomized controlled studies showing that this has great benefit. That's true kind of across the board for us. But that is the way that it's used. Let's talk about fibrinogen for just a sec. So fibrinogen is a clotting factor that's made in the liver. It's obviously essential to coagulation because the conversion of fibrinogen to fibrin is kind of the core function of the coagulation system. It's the final factor in the traditional coagulation cascade, as we know. But fibrinogen is fairly sensitive to things that can happen in certain situations. For example, fibrinogen is really sensitive to consumption and dilution during massive hemorrhage. Consumption because you're trying to clot all these places where you're hemorrhaging, and dilution because of the resuscitation efforts. So you can consume and dilute fibrinogen pretty quickly in massive hemorrhage. You can also have a problem with fibrinogen when you have liver damage. It's a product that's made in the liver, obviously. DIC, disseminated intravascular coagulation, you can get significant consumption of that fibrinogen as you're clotting lysing in DIC. And also, one of the most famous places that fibrinogen can get damage is in cardiac surgery, through a combination of blood that's being used, things that are being transfused, and consumption and damage to the fibrinogen as part of the bypass process. Once we get to the point, though, that where we don't have enough fibrinogen, you can see there is a fairly strong, and honestly, again, the quality of the data varies, but there is at least some correlation with bleeding, with hypofibrinogenemia, especially in trauma and cardiac surgery, and in significant hemorrhage, especially in cases like obstetrical hemorrhages. Those are big deals, and those are places where we definitely see at least some association with bleeding with too little fibrinogen.
Okay, so Joe, with some of the other blood products, for example, with red cells, we always say, hemoglobin of 7 or below, you may consider transfusing. With platelets, we say if otherwise, I guess, quote unquote, healthy patient, but platelet count of less than 10,000, although I don't know how healthy you are if your platelet count is less than 10,000. But, we say, we have some sort of rough guideline of when we should transfuse. What about with cryo?
We do have some guidelines, Heidi, but those guidelines are really, our understanding of those guidelines are changing. We have a fairly straightforward guideline that's been used in the United States for decades for fibrinogen replacement, and that has been 100 milligrams per deciliter as a point where if someone's bleeding and their fibrinogen is less than 100 milligrams per deciliter, it is reasonable to replace their fibrinogen with cryo. Now, just to be clear, those of you outside of the United States, I think the United States might be the only country on earth left that still uses milligrams per deciliter. So when I say 100 milligrams per deciliter, that correlates to 1 gram per liter in other countries. So I'll try and make that correlation, but forgive me if I don't. Again, we're wacky and stubborn in the United States. Okay, so we've used that 100 milligrams per deciliter number for decades, as I said, but there's a growing body of literature and some really good studies, some of which I'll put in the show notes as well, that describe that, man, maybe that might be too low. And in fact, you might want to think about going for a higher threshold of at least 150 milligrams per deciliter or 1.5 grams per liter. Some say as high as 200 as a cutoff. In other words, if someone's bleeding and their fibrinogen is below that, you might want to consider replacing their fibrinogen with some sort of fibrinogen supplementation, whether it's cryo or another product that we'll talk about shortly. The one other thing to be careful of is this is really important to remember. In pregnancy and obstetrical hemorrhages, you can get fooled. And that's the reason for that is that the fibrinogen levels automatically, kind of naturally, as part of pregnancy, go up substantially. So if someone gets down to 100 milligrams per deciliter or even 150 and they're pregnant and with like an obstetrical postpartum hemorrhage, if you use that number to say, oh, they're fine, they may not be. You really may have to think about 200 or 2 grams per liter, 200 milligrams per deciliter as a threshold or more in a lady who's having an obstetrical hemorrhage. And then there's one more thing that goes with this, Heidi, and that's that we're discovering in recent years that we're seeing a whole lot more situations where cryo is being given without even specifically knowing the fibrinogen level at all in someone who's bleeding, and that's because of the increasing use of things like thromboelastography and ROTEM, TEG and ROTEM in the operating room that kind of guides the administration of cryo. That's a really important thing to remember. There's a growing amount of cryo being given to replenish fibrinogen where we really don't know the count. It's being based on those studies. So once we decide that we need to give cryo for whatever reason, I mentioned this before, there are 2 main ways to replenish fibrinogen. And the first obviously is cryo. So we've talked about that. The second thing though, is part of the reason that I alluded to earlier that cryo is in other countries having some decreased use. And that's because there is now available a product which is fibrinogen concentrate. It's treated, it's theoretically virus free, and it's designed to replenish cryo in a rapid way. It's approved really in most countries, but it's not necessarily approved for this indication. For example, in the United States, and I believe in the UK and Canada and Australia, it's actually only approved for congenital hypofibrinogenemia and not acquired hypofibrinogenemia like we're seeing in the situations that I was mentioning earlier. Now, fibrinogen concentrate, simple product, really. I mean, it's a pharmaceutical, so it comes in a vial. It tells you on the vial how many how many milligrams of fibrinogen are in there. You just reconstitute it. I think it's just with sterile saline and inject it. It's really simple, easy, and fast. And it seems to work well in studies that have been done so far. But in the United States, it is still off label for these particular indications.
Okay, and is it expensive, Joe? Do you know?
Yeah, it's considerably more expensive than cryoprecipitate, and I don't know the exact numbers. I've seen numbers suggesting as much as 5 times or more expensive. But when you factor all of it in countries that are using it for acquired hypofibrinogenemia, which is most places outside of the U.S., U.K., Canada, and Australia. What they are saying is that the speed that you're able to give the product with, the lack of a need to do additional blood banking stuff could contribute to the cost actually being closer to equal. Not really my expertise, but yes, the short answer is the product is definitely more expensive.
Okay. And so we've talked about how cryo is derived from FFP. So therefore, everything that's in cryo is also an FFP.
Right.
So why not just use FFP for acquired hypofibrinogenemia?
It's a great question, and it's important to understand this, that while there is definitely, obviously, more fibrinogen in a unit of FFP than there is in a individual unit of cryo, the concentration of that fibrinogen is considerably lower. Remember, with cryo, we're yanking in at least half, in some cases more than half, of the fibrinogen that was in the original bag of cryo, and the original bag of FFP, and concentrating that into a final volume of about 15 mils in cryoprecipitate. So you're able to give a whole lot more concentrated dose of fibrinogen to someone when you're giving cryo than FFP. And actually, there have been a couple of studies that have looked at this to try and, it was partly in vitro, to try and calculate whether you could keep up with the fibrinogen needs of someone by giving them FFP as opposed to giving them cryo or fibrinogen concentrate. And actually, mathematically, it actually doesn't make sense. You can't really keep up with the need when someone's getting a massive transfusion because they're bleeding heavily or whatever. You can't really keep up with it with a fibrinogen. Now, it's going to contribute, of course, because there's fibrinogen in FFP. Of course, there's fibrinogen in platelets that people are getting in those situations, but it's just not enough, generally speaking, to keep the levels where we want them.
Okay, so Joe, if we do decide that someone needs to get cryo,
right?
Well, how much do we give?
Yeah, honestly, there are ways to calculate this. And in fact, unfortunately, you guys that are pathology residents, you may well get asked this on an exam. So I'm going to cover this in another forum. We don't have time to do this today. Plus, it's hard to do the math with audio only. But I'll cover this on the show page, so don't worry about it. But really, honestly, practically speaking, most people don't get too complicated with this. In general, there are some guidelines that say that if you give 1 unit or 1 bag of cryo per 10 kilograms, that'll roughly increase the fibrinogen level in the range of 50 milligrams per deciliter. Okay, and that would be 0.5 grams per liter if you're doing it that way. So that would correlate to 2 pools of 5. In other words, a 10 pack for a 70 kilogram person or so would raise the fibrinogen in the range of, again, 0.7 to 1 gram per liter, or 70 to 100 milligrams per deciliter. But honestly, most people don't mess with that, Heidi. In general, cryo will often get used in massive transfusion protocols and obstetrical hemorrhage protocols, where you'll just throw in 1 pool of 5 cryo basically with every other massive transfusion pack. In other words, most people use massive trauma packs or massive transfusion packs where they give like 4 to 6 red cells, 4 to 6 plasmas, 1 apheresis platelet in a pack, in a group. And generally speaking, what a lot of those protocols will do is that, like every other pack, they'll include a pool of 5 or more cryoprecipitate units. Again,
and that's what we've been doing in the places I've practiced, exactly what you described.
Yeah, it's very common to do it that way. Again, just because in the heat of the battle, it's kind of hard to sit there and figure out. You would have to
make calculations.
You don't want to mess with that, generally speaking. So that's just a useful tool, and most people will do it that way.
Okay, so Joe, you've been, I think, kind of mentioning it throughout the talk,
Mm-hmm.
all the historical uses of cryo,
Yeah.
but can you summarize all the reasons cryo has been used in the past?
Sure, I can. This will have to be high level because there's a lot. There's a lot that cryo has been used for historically. As just to be clear, nowadays, by far, the number one use of cryo is to replace fibrinogen in situations of surgical or massive hemorrhage, et cetera. And in fact, I want to mention this before I go on that in some studies, the number one indication or the number one use of cryo has actually been in cardiac surgery in patients that are bleeding during cardiac surgery. But that's a topic for another day. So we'll leave that there. But just a few of the indications for cryo being given. And again, a lot of these come down to the things that we know are in cryo. It's been given for, in fact, one of the more common things that used to be given for in single packs, and this goes to John's email at the beginning, is as a part of fibrin glue. And that's kind of a weird product where you would take a unit of cryo or 2 units of cryo, you would mix it with thrombin from the pharmacy. Typically, that was bovine thrombin and a little bit of calcium. And you mix that together and it basically makes this pasty stuff that you could paint onto raw surfaces, really useful in like liver surgeries, for example. Unfortunately, what we found is that bovine thrombin, it could cause problems. You could make antibodies against bovine thrombin and antibodies against bovine factor V, which was often included in there. And that has major consequences because that antibody against bovine factor V cross reacts against human factor V. And I've seen patients like that can be a mess. They bleed like crazy. So
I have seen one patient like that too.
Yeah, it's not an easy thing to deal with. So generally speaking, there are safer and non-bovine thrombin involved ways to make fibrin glue nowadays. In fact, there are FDA approved preparations that are just ready to go. You don't have to use cryo at all. So again, we don't use that very often. For von Willebrand factor, while von Willebrand disease is pretty common, there are other alternatives to cryo, generally speaking. Things like desmopressin or DDAVP can be used in patients with von Willebrand's disease, for example, with type 1, which is the most common form of von Willebrand's disease, and in other forms of von Willebrand's disease where DDAVP doesn't work as well. You can use human-derived factor VIII concentrates that also include von Willebrand's factor. I would really consider cryo kind of the last option in those cases. We also mentioned factor 13, which is a part of cryo. But while factor 13 deficiency is really, really rare, like 1 in 3 million patients, it can be seen, of course, but in most countries, including the United States, there is an approved virus-treated, I think it's a human, I'm pretty sure it's a human factor 13 concentrate that will... there is, again, a better choice than cryoprecipitate. So you don't see it used for factor 13 deficiency very often anymore either. And a couple of other ones, one that I really want to mention because I actually do believe in this, and this goes back to von Willebrand's factor. In patients who are uremic, patients with chronic renal failure in particular, they have a bleeding disorder that results from their platelets not sticking very well. Their platelets don't stick to raw surfaces very well, and that interaction is mediated. Platelets sticking to raw surfaces is mediated by von Willebrand's factor. So the idea with giving cryo in patients who have uremic bleeding, in other words, they're bleeding from mucosal surfaces and they have petechiae, like, they have a platelet issue, but they have normal platelet counts. The idea is to give something that could help their platelets stick to those raw surfaces better, and cryo could supply that von Willebrand factor. Now, with that being said, Heidi, DDAVP could kind of do the same thing, and there are some other things that we've talked about, like conjugated estrogens and things like that for patients with uremic thrombocytopathy, but it is something that's in the toolbox that could potentially be used. And then the last one I wanted to mention was not something I've personally seen, but in patients who come in and get thrombolytic therapy, like tissue plasminogen activator or TPA, patients that have strokes, for example, if as a result of that they get intracranial hemorrhage, there are some protocols that in terms of treating that intracranial hemorrhage, we'll talk about using cryo in those situations. I don't think there's a lot of data
Very
on that,
interesting.
but there's the thought is that might work. Honestly, I'm not sure how it would. I'm not sure what would reverse the effect of TPA in cryo, but again, that's the topic for another day. But that's those are kind of the things that historically we've seen. Very, very limited uses for those now.
Got it. Okay, so Joe, you've mentioned with a lot of new and upcoming pharmaceuticals, a lot of new, or not even new, but factor concentrates that are available on the market. We can cover, for example, factor 8, we can cover von Willebrand, we can cover factor 13. There's even a fibrinogen concentrate. Right. As you said, it's not currently approved for acquired fibrinogenemia, hypofibrinogenemia, but probably in the years to come. So with all of that, what's the future for cryo look like?
Sadly, because I'm a blood banker and I love blood products, I would say it's not too bright, to be honest. I mean, realistically, because fibrinogen concentrate does seem to work really well in the studies that have been done for the main remaining indication for cryo, which is again the acquired fibrinogen deficiency. It's likely that fibrinogen concentrate will be approved for that indication in the United States before too terribly long, and in other countries that still haven't approved it, like Canada and the UK, et cetera. Realistically, I think it's probably ultimately going to prove to be a better product. The fibrinogen concentrate, you can give it much more rapidly. You're not dealing with things like transfusion-related acute lung injury. We didn't really talk about that, but cryo has been shown to have the potential to cause transfusion-related acute lung injury. Obviously, there's such a small volume, it's not likely, but it absolutely has been shown to do that. Even though it's more costly, you may make up for the increased cost by having a more rapid and potentially more effective dose by using the fibrinogen concentrate. I really believe that once fibrinogen concentrate is approved, which, as I said, it probably will be, cryo is not going to have a whole lot of remaining utility. And we may look back on this podcast a few years from now, Heidi, and go, oh, wow, ha, 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 remember when we used to use cryoprecipitate? Silly us. Before we go, though, I actually do want to toss out a couple things. That these are just really practical tips, primarily for path residents and people working in transfusion services for scenarios scenarios that should throw up red flags for you. When you hear about someone using cryo for these indications, these are things that you should really push back on. So why don't we? You okay if we do that, Heidi? Just a couple quick things.
Sure.
Okay, so I talk about these when I teach pathology residents, often kind of the myths of cryoprecipitate. The first one and the most common one that I see is people that are transfusing someone who's really volume sensitive. So they're in congestive heart failure, but they need replenishment of something in their coagulation system that would normally be treated with FFP. And they'll say, oh, well, my patient is volume sensitive, so I'm going to give them cryo instead. No, that's a bad choice. Remember, if you've made it this way all the way through the podcast, you know that doesn't make sense, because cryo does not have all the stuff that FFP does. It's not an equivalent product. Please don't use it that way. The second one that we'll see is in a similar situation where someone's volume sensitive, but they need reversal of warfarin, and it's kind of a subset of the first one. Again, that's not going to work. You don't have, remember, warfarin reversal, you're talking about replenishing 2, 7, 9, and 10. And out of those, let's see, 2, 7, 9, 10. We're not talking about anything that's in cryo. It's not going to help you. So not a good choice for that. Another thing that I want you to push back on a little bit when you can, if you have someone who is bleeding, who doesn't have any evidence of hypofibrinogenemia, or doesn't have any evidence through one of the point of care methodologies like TEG or ROTEM, to throw cryoprecipitate at bleeding without any explanation, not necessarily the best choice. I know okay. People do it, and it happens a lot, but realistically, there's no evidence that cryo really will have any effect in those scenarios. And then the last one that I want to mention real quick is that some people will try and correct the coagulopathy associated with liver failure by using cryoprecipitate.
I see that a
Yeah,
lot.
that does happen a lot, and it really, again, doesn't make a whole lot of sense. Really important to remember this: the coagulopathy and liver failure. Dr. Jeannie Callum talked about this a few episodes ago. It's a balance between a coagulation ability, which is decreased, but also coagulation lysis ability, which is decreased. In other words, it's both the ability to clot and the ability to lyse that clot are diminished. So you end up in a balance that really doesn't result in patients bleeding much in most of those scenarios. So, but if you're trying to treat numbers by throwing cryo at that liver failure coagulopathy, which actually, quite honestly, might help the numbers because if you're in liver failure, you're not going to be making as much fibrinogen, but you might throw off that balance. You actually might put them in a situation where you're giving them the ability to clot while not messing with the ability to keep them from clotting. And so theoretically, anyway, you could make them hypercoagulable by doing that, and that is not a good choice.
Okay. So with that, I'm going to conclude today's BB Guy Essentials. I want to thank all of our listeners for listening. I want to thank Dr. Joe Chaffin for teaching us everything we need to know about cryo. And most importantly, we learned today why Dr. Joe Chaffin went into pathology, why he decided to pursue blood banking, and how he got into teaching blood banking, which I think are the top 3 essential things we learned today, aside from all the cryo talk that we did for the past hour or so.
You're too kind.
But thank you all for listening. Please continue to email your questions, and we will try to answer them as often as we can. Thank you again.
Hey guys, Joe with a couple of closing thoughts. First, thanks very much to Dr. Heidi Shafi for co-hosting this episode. I always appreciate it, and it helps to keep the conversation going, and hopefully you guys enjoy the interaction as well. As before, I'm working on some new projects. I hope that you'll do a couple things. If you get the chance, go to iTunes, rate the podcast. That really does help. Go to the Blood Bank Guy website and sign up for email updates. No spam, I promise, but we'll just keep you up to date with stuff that's coming out on the website. And finally, pathology residents, if you guys are interested in hearing more about a project that I'm working on for pathology online blood bank review coming in January 2017, go to bloodbankguybootcamp.com and you can sign up there for again, the no spam interest list. So that's it for today. I really appreciate your time. Thank you so much for listening. As always, as you go through your day, I hope that you smile. I hope that you have fun. And above all, never, ever stop learning. Thanks a lot. We'll catch you next time on the podcast.